Good evening, ladies and gentlemen. I'm Rebecca Doctor. My senior thesis is an analysis of the cost, access, and quality of the Affordable Care Act, otherwise known as Obamacare. 2 weeks ago, the Senate and the House passed a bill for a new budget that laid the groundwork for dismantling Obamacare. Many Republicans claim that the healthcare system is too expensive, and most Democrats return that you can't just take insurance from millions of people who gained it from the act. There are plenty of strong opinions surrounding this piece of legislation, but I am going to focus on the more measurable results of the act. Before I begin, though, let me make a disclaimer. There is a vast array of problems surrounding this act, not the least of which are ethical considerations, such as whether or not funded abortion, or questions of political policy, for example, whether or not healthcare is a constitutional right, or to what extent the federal government should be involved. These are valid and worthy objections and should be considered in a well-rounded evaluation of the Affordable Care Act. But because I had to narrow down the scope of my research, I chose to take the natural first step of such an evaluation, that is, judging the act based on what it said it would do. Thus, my thesis limits its scope to a consideration of the Affordable Care Act's impact on the United States' existing healthcare system, according to its own categories of economic cost and effectiveness with respect to access and quality. Mark J. Roberts, a health systems expert from Harvard, described how to measure these same categories. Cost can be measured by the average amount spent per capita on healthcare services, or else as a percentage of the gross domestic product, which provides perspective within the U.S. economy and can be compared to the expenditure of other countries. Access, at least in the Affordable Care Act, is based on health insurance, that is, making more people able to be insured. Quality is difficult to measure, especially given the relatively short time the Act has been in effect. But besides sizing up a hospital's amenities, or having the most expensive procedures, quality healthcare should produce good results. What did the Affordable Care Act claim to do? The stated goal was to expand access to healthcare coverage, that is, to make sure more people were able to be insured. It required people to purchase insurance if they could afford it, or else pay an extra tax, and it expanded the number of people eligible for Medicaid by raising their requirement to 133% of the federal poverty level. It created the exchanges in order to facilitate the sale of insurance, along with several other programs, for example, the Consumer Operated and Oriented Plan, purposed to help create nonprofit insurance companies. And the act prohibited insurance companies from denying basic coverage to people with pre-existing conditions so that they would be able to be insured to some extent. Although increasing access, the Affordable Care Act aimed at containing costs by, quote, reducing waste, fraud, and abuse in public programs, by funding anti-fraud activities, and enhancing oversight on healthcare suppliers. It created a board to work on containing the costs and cut spending on certain parts of Medicare and Medicaid, such as the elimination of the Medicare Improvement Fund. With an eye towards quality, the Affordable Care Act funded research and other programs to increase the quality of care in specific situations, such as hospitals. It also required transparency by the disclosure of health suppliers' finances and data. In short, the Affordable Care Act was a multitude of programs aimed at ensuring that everyone at least has access to health insurance, while attempting to reduce costs and maintain quality. So what did happen? It is important, first, to remember that looking at data cannot prove causality. For example, if costs decreased, it would not necessarily be due to the Affordable Care Act, given that there are a multitude of other economic and societal factors which could have a bearing on these statistics. But though it may not prove a causation, it does establish a correlation, so that if a statistic markedly changes after the act took effect, without some other clear reason, it is strongly probable that the Affordable Care Act was part of or was the cause. The first thing we are going to look at, then, is cost. The Affordable Care Act, to the extent of its correlation, has failed in reducing or even containing cost. Instead, healthcare expenditure continues to rise. On a national level, healthcare spending has increased, both in its real amount and as a percentage of the gross domestic product. Naturally, the average spending per capita has also risen. And when compared to other countries' healthcare expenditure, the United States outspends them all. We spent twice as much as or more than countries such as the UK, Italy, Korea, or Mexico in terms of GDP. But the greatest success of the Affordable Care Act was its expansion of access to insurance and thus healthcare services, which is the second category I look at. The number of uninsured people of all ages has steadily decreased after the Affordable Care Act. From 2010 to 2016, the number of uninsured decreased from 48.6 million people to 27.3 million. And the percentage of uninsured also dropped from 18.2% to 10% over the same interval of time. In analyzing access, the Journal of Healthcare Organization, Provision, and Financing conducted an inquiry into the effects of the Act on access, specifically for low-income adults with a chronic illness, mental disability, or substance abuse disorder. These people would have an evident need for healthcare services, such as hospital stays, doctor visits, or access to prescription drugs. And those who were covered by Medicaid, that is, were insured, had much better healthcare access and higher use than did those who were uninsured, according to this report. Thus, as far as access is concerned, the data shows that access increased. Having looked at cost and access, the third category is quality. Quality is difficult to measure, especially since changes in aspects such as preventive care would have more payoff 60 years from now as opposed to 6. But some general health statistics can be analyzed. The life expectancy rate stayed roughly the same, going from 81 years in 2010 to 81.2 years in 2014. So there has not been a greatly marked change in the general health of the nation. But safety measures in hospitals seems to have improved over the 2010 to 2013 time interval. Adverse drug events, infections, and problems such as ventilator-associated pneumonia in hospitals noticeably decreased, which reflects an improvement in hospital conditions. And so the overall quality of care seems to have stayed the same, if not improved. Ultimately, then, the Affordable Care Act failed in reducing costs as projected, but succeeded in increasing access to health care through health insurance, and may have increased the quality of health care to some extent. Thus, in its own terms, the Act succeeded by increasing access, but failed in terms of cost. This analysis would just be a first step in evaluating the Affordable Care Act, and given the present political climate, it is unlikely that any further time will be given for the Act to have long-term effects. But what I took away from this study was that the Affordable Care Act did increase access, but did not really solve any of the fundamental problems that have and continue to raise costs. And so the Act's success in increasing access would have been better for the long term if it had also been financially sustainable. Thank you. Mr. Hoffmeyer?
What are some of the factors that you determined are raising costs?
So, my analysis didn't go into the main workings of the Affordable Care Act too thoroughly. However, by increasing the eligibility for Medicaid, it's allowing more people to be insured. However, now the government is subsidizing that many more people to be insured. And so that would definitely increase government costs, just because giving more access means that you have to pay for it somehow. And although they did try to cut spending in some parts, and they've created groups to try to solve this problem, it hasn't been terribly effective.
Costs generally increase year over year as it is, and there were projections of the cost of Medicare or the medical care to the society before the act was invoked. How did those costs, the projections, compare to what actually happened? Have any idea?
I don't have the exact numbers up here with me. However, part of it is that comparing it to the GDP, so that would account for inflation by comparing it to the gross domestic product, because then it's just a percentage that would go along with what the country is making. However, so I think the Act's aim was to reduce costs, but it didn't, there was a trend of costs continuing to increase, but it didn't stop the trend, really.
In your research, how much information is out there from the medical provider community on their giving their feedback on the impacts of this Affordable Care Act? Is there a lot out there now that the community is offering from the provider's perspective on what it's doing to their industry?
Wait, could you rephrase the last bit of that again?
The providers, the ones that are actually providing the health care through the Affordable Care Act. Is there a lot of information now being developed out there from a research perspective as to what their opinions of the impacts of what the Affordable Care Act is having in their service, community, industry?
Yeah, that's a really good inquiry. I was actually a little bit overwhelmed by the amount of research being done in this area. And so what I was looking at was broader statistics. So part of the Affordable Care Act did require healthcare providers, they said transparency in data. And so there are places like the Organization for Economic Cooperation and Development that just had data year after year on general health statistics. And so I think that would be one place where someone searching for them could go. But also just because there are a lot of different themes going into this act, like politics and ethics, it's hard to look for an objective standpoint on what's happening. And so that's why I narrowed it down and limited it to looking at data. Mr. Hoffmeyer?
Sorry to hog your attention. You've used a lot of wonderful language that has made me happy, that has showed that you're thinking. How has this project helped you learn to think better?
Well, it's definitely taught me about finding sources. One thing I didn't realize was how hard it was to find out whether your source was credible or not, because sometimes sources, they appear to be credible, but sometimes you don't know. So my teacher actually pointed out to me that there could have been bias in one of my sources, and so I had to think through, okay, what would that bias have done? Is this objective enough information that I can still treat this as a good source, or should I take that bias into account? So that's a really good thing I've learned.